some adhesive in orthopedic surgery operation to provide better stability for the area. And so sometimes I told you there is a kind of complicated multi-fragments injury, and as a result you have different parts. It's hard to just provide reduction with a simple method of fixation, or probably with a kind of external cast or plaster parts. So as a result, we are using different type of the adhesive orthopedic devices to make the stability, immobilization much easier. It's important to make the stability much easier compared to the different situation, different aspects. So the easiest type of the immobilization is the cast, or a specific type of the plastic. We call it plaster of Paris. This is a specific type of plastic we are using it to create such a kind of immobilization for the area instead of cast. The cast is very heavy, so as a result, they prepare some other materials that is with the quality of the plastic, and so it's so lighter compared to the cast. Okay, at the same time, we do have some kind of traction that can use for a kind of fixation. So I told you it's very important to come back to for the normal anatomical position or approximate normal anatomical position. And so as a result, sometimes if the distance is much more far, so it's very hard to bring it onto end-to-end position. So we have to use a method to provide or distract the area, to push the area to the normal spot. And that was the reason we are using traction, different kinds of traction, for the reduction or realignment of the two fragments of the bone. And so, for instance, for the fractures, you have it in the femur, or the fractures, we have it in the spine area. We are using this kind of traction, as I told you. So there are different types of the traction based on the different type of the fracture. And there are, for instance, Brown or Bryant. There are the traction that they're using for the area of the fracture. Okay, we do have external fixator and internal fixator as well. The external fixator, both of them are some material, steel material, stainless steel material. And this is not from the quality of a copper or, for instance, gold, or for instance platinum, or even for the some purified alliage or material. We do have some kind of we do have some kind of alliage mixture between different materials to have better stable quality of the device, orthopedic device. And so the most famous quality of these devices is alliage under the name of 316L. 316L. It's a mixture between vanadium, nickel, some kind of iron, and also some level of neodymium. So it creates a specific mixture of material elements that help you to cover the chance of infection. How? Because when you have a kind of pure material such as iron or, for instance, copper, so there is something extraordinary inside of the body. And whatever, if a pure material would be exposed against water, against damp situation, so the chance of the infection would be higher. So wet situation. And you know, inside of the body, always all of the tissue are open to the wet or something. We call it that actually corrosion or deterioration or destruction. The chance of the destruction close to water, the destruction in assure, in bank. You know assure, what is the assure? Assure, the area close to sea. Assure, bank. In Farsi Sahel, might be close to Arab. Anyhow, the chance of damp weather, wet weather is high, and if you have a high level of wet weather, so it affects on the area and destruct the area which is close to the wet. So because of that, we call it corrosion. It's a kind of destruction or deterioration. C-R-U-S-I-O-N, corrosion. And so, because the corrosion level is so high, we are using a kind of specific mixture between material that is 316L. 316L is a mixture of nickel, iron, vanadium, and neodymium, and also platinum that decrease the chance of the corrosion lower. Okay, we have different devices. We can use these devices to provide kind of fixation inside of the body. And if the devices, the orthopedic devices, is inside of the bone, we call it internal fixator. And if they will be attached to inside of the bone, and at the same time they will be related to outside of the bone, we call it external fixator. Some people believe that if they are external fixator if they are in connection with outside environment. And some people believe that, okay, if the device is close to the bone but inside of the body, it's external fixator. No makes difference actually, it's just a different definition. It doesn't matter to worry about that. Okay, so you have to review, a simple review on fixator. Why? Because type of the fixator shows us how much stability does we have for the area of the fracture. If you see that the stability is good, okay, so you can reach the stages of movement sooner. But if the stability was not good, so the movement you want to try for that, our job is pain and function. You want to say that, okay, do active assistive device, active movement, something. If the stability was not good, if the ORIF was not good, so you have to postpone your movement suggestion for sure. Whole of these ideas, these assistive orthopedic device are ORIF. What does the meaning of ORIF? ORIF. Open, reduction, internal, fixation. Open, reduction, you are reducting the area and opening under the surgery, because you cannot use ORIF on the skin. You must go inside. So open reduction, internal going inside, and fixation, because it fixed two fragment area. Okay, in general concept, in general name, it's ORIF. So we have different type of the ORIF based on the type of the fractures, and when you see ORIF in the picture, X-ray, you can say that, okay, the stability is good or not, or I can reach this kind of movement sooner or later. So it does help you in this way. The simplest type of the ORIF is plate. Different type or size of the plate, and the quality is 316L. All of them, the quality of all of them of 300, this is a kind of mixture of elements. 316L. Okay, so this is simple plate, and you can see that you can put it on two parts of the fragments. Okay? Oops. I need probably another cell phone. Can you give me your cell phone, please? There is no protection on there, is there? Maybe broken. Is it protection? Yes. Okay. If you have a kind of fracture in this way, this is the line of the fracture, okay? The simplest type of this stability is just a kind of plate, and fix this plate as far as you can cover the line of the fractures. And you can use screw 1, 2, 3 onto how much to make a kind of stable situation for the area. And the screw, you see the screw right now here. You see the screw. There are different screws. We do have different size of a screw, and they are getting inside of the plate exactly like a kind of industry a screwdriver inside of the body, and fix the plate as a kind of fixation over the bone. It's exactly like a kind of, you know that when you are looking to the devices using for operation, orthopedic surgery or something, you see, it's look like a kind of laboratory for industry or carpentry or something like that. A screwdriver, hammer, and such a kind of different gear or something in a sterile environment. Okay, so this is the simplest type, and you see that there is different shape of the plate. Why different shape? Because we have different shape of the bone, so probably they can use, for instance, for the plateau or epicondyle or somewhere that you have a little wider area for the bone, so they can cover the fractures close to joint or something. So imagine just the most important items. You are not able to destruct the tissue you are working under. So when you have lots of screws all close together, actually you are destructing the area, demolish the area. And you know that main center for the osteoblast generation is central canal. Central canal. If you destruct the central canal in one place, you are decreasing chance of healing, chance of the healing. So it's very important to be confident that you are providing this stability with the lower amount of a screw, as much as lower possible. Sometimes it's not possible because of the type of the fractures, number of fragment area, sometimes. But in any case, probably in difficult situation, the surgeon didn't try for a kind of, did have to provide much actually number of screw in limited area. So it's not general. Always the surgeon try to use the lower amount of the orifice, including the screw, to decrease chance of destruction or problem. Clear? Okay. Yes?
Is the same, use the same space for the injury, for the big injury and not the injury?
For what?
Big injury.
Okay. So, you know there are a lot different type of the line of fracture, for instance. You know that the oblique, spiral, transverse. At the same time, we do have different type of the orifice, different type of the plate, okay? So, based on the situation, there are tools. The surgeon must select the most appropriate one to put it on the fracture. The whole idea is increase chance of stability or decrease chance of disability, disability. So in any case, we must choose the best one to provide the best actually stability. For the oblique fracture, so a very simple method of the plate can provide stability. Why not? If we want to be much firm, we are using that one. DCP, a specific type of the plate. DCP, a specific type of the plate. D, dynamic compression plate. DCP. When I'm telling you DCP, I means this one. And what is the difference of DCP with a normal original or actually the common plate? What is the difference between them? In DCP, you have a kind of ellipsoid hole. It's not just simple circle here. It's just simple circle, right? Here it's ellipsoid, two part, and it helps you to use a kind of a screw inside of the body, and then at the ending stage, slide to the screw to the side. So use the screw inside of the hole, and then when you reach at the end, slide it at the side, and it would be locked. So there is no chance to remove this screw with no reason. If you want to bring it up, so you must slide it at the middle part and then throw it away. So you cannot remove it from that point. You cannot throw it away from this place, this side. It's exactly happened if some probably guys work in a kind of industry. You are using a screwdriver, you see what I'm saying. Actually, the stability in dynamic compression plate is too much. The stability in dynamic compression plate is much more than common plate. Okay, are you understand? Did you understand? Okay, so it's exactly like that. You're getting inside and then a slide. It will be locked. Inside then, so you want to remove it, you must slide it and then remove it. You cannot remove it from that point, okay? So there is another type of a plate. The name is buttress. It's using for the area which you have a kind of epicondyle, especially for, what is the name of this bone? Yeah, easy. Okay, especially you can use it for the tibia area, and see there are a specific type of the screw, put it inside of the, fix the plate, with the bone. You see, this is a specific type of a screw. Why? I'm considering one positive mark for any who can explain it. You know, the screw is different with that screw. Yes, Mustafa.
Because this is French bone.
What?
It's French.
So, what you explain?
So it's more flexible. More, يعني, it's not solid, 100%.
The difference is this is cortical bone, this
Yes.
is a spongy.
Sponge.
Good. But why you are using this shape?
Uh-huh.
Can you judge it? Can you explain
For
why?
stability, for stable, for balance.
I think Mustafa can say that, but just a little think about that. No memory, no memory. No need memory. It's a kind of conclusion. You have what? Sorry, I'm not understanding. Tentricle. Central canal. Central canal. Just work on your ability. You can speak, but just pronunciation. Okay. Okay, central canal. Okay, so central canal is not important because I told you we are not trying to destroy central canal. We are trying to keep it safe. So central canal is not important. Something else is important. Come on. The mark is waiting for you. Yes. For? What does that mean? Balance. When you hear something about mark, say anything you think.
Maybe because in this amount of cartilage, this cartilage is
Better clarification. You see, the difference between compact bone, cancellous bone, it's very strong, completely well structural, okay? Very strong, high powerful, it's low strong, it's weaker compared to that one, a spongy type of the tissue. So it can be broken with huge amount of the energy. Needs lots of energy for that. Here it can be broken with lower amount of the energy. It's exactly like a sponge, right? So easier to be broken again. Harder to be broken again. So it can tolerate a kind of injury or adding some kind of injury. You're using the screw, it makes some injury inside. Actually, you get a kind of rest for this area. It's rest, there is no injury because it's just a kind of, like a kind of wire. Wire, you know wire?
Yes.
Without any kind of extra injury. They are not rotating. It's not like that. It's not like a kind of sharpness or something. This is a kind of resting area which is there because it's easier to provide injury in the cancellous bone, and that one you have a kind of dendrite because you want to provide a fixation at the ending part. So, but here it's a strong, you need lots of energy to provide next injury, so no worry about the tissue. So that one is helping to create no injury, no extra injury for the cancellous bone, which is weaker and open about the injury. So, easy. The mark is here. It's for me.
Yes, that's for you.
Okay, so the buttress plate is for the plateau of the tibia, epicondyle, and the shape is close to the area of the ending bone. And you know this is long bone. This is a kind of long bone. And see, another extra mark for you. When you have a look to this kind of fixation, come on, Mustafa, have a look here. When you have a look to this fixation, it's good fixation. Buttress screw and buttress plate and a screw. Okay, so screw is here. And so, which problem may have a kind of risk for this patient? Which problem? Risk for arthrosis or something. What is the risk?
Risk in the bone, for bone destroyed.
I was asked to decrease number of my teaching hours per day. At most six hours, it will be fine, not 8 hours. Sorry?
Destroyed the cartilage
Why?
because
The chance of destruction is higher here.
شنو يعني ليش هذا شكل خطر ممكن؟ شنو ليش شكل خطر ممكن؟
Have a look to the shape of the fracture. Can you understand the line? How can you get line of the fractures?
non-competitive fracture.
Line of the fracture is a kind of complicated fracture.
Yes.
It's not simple one.
Doctor, if the patient have weights, very high weight,
Then we increase the chance of the arthrosis.
شنو الخطر اللي ممكن يسبب بسبب
Not really unstable because they're using buttress plate plus screw, so it's a stable. Because of what? That chance, last chance.
Doctor, this area is spongy.
Area what? Sorry, I can't hear Zainab. Sorry.
This area, this is spongy bone. Because it is a spongy bone. She is easy to.
Yes, there is a spongy bone,
So
but
it
there is
is
something
easy
something
to-
else. No, we talk about the spongy bone.
Yes. But
No,
she can't.
the mark is for myself. So, see the line of the fracture? Okay, you are providing, the surgeon is providing kind of fixation for different fractures, right? Right?
Yes.
Okay, still, we do have a small part, doesn't fix. So, the chance of being these two far from the body of the bone would be high. I'm talking about these two parts. Okay, and if it's happened, because there is no fixation on them, if it's happened, what is happening? They will be inside of the joint. We call it loose body, free body, loose body. And they may force some part of the cartilage, or even during the movement of flexion and extension, they will be located and trapped between two parts of the joint and increase the amount of the destruction, deterioration, destruction. So, the chance of loose body is higher here, and it may lead a kind of sooner force and arthrosis, sooner arthrosis or early arthrosis. This is the problem of this picture. Okay, so there is another type of the plate, we call it 95-degree condylar compression plate. Why is 95 degree? Because when you have a look to the end of the femur, end of the tibia, you see that the epicondyle is located with a degree of 95, not exactly 90 degree, They are not vertical, completely horizontal and vertical. There is just a little over them. Because of that, we call it 95 degree. The angle of this actually plate is a little more than 90. So why condylar? Because it can be used at the end of the femur or tibia, and the long bones, or even for the humerus. So we call it condylar, 95 degree. Why compression? Sometimes it's not possible to keep stability just with a kind of plate. Okay, so they're using this plate, but still it may actually provide a kind of movement between these two fragments, or somehow a slightly slide at the side, or anterior, posterior, anything. So as a result, actually, since we want to completely keep it or use a kind of high level of stability, we are providing such a kind of fixation. That means actually such a kind of, we are using a kind of a specific hole inside of the wall, and then use a screw inside of that. The screw is inside of the hole, so they keep it so strong. But if you are using in the tissue of the wall, so there is chance of the movement, something like that. But if you put some hole inside and then use the screw, it will keep it. For instance, you want to hang a kind of table or something like that. Because of that, so that means this is the items that happen. The artificial hole, and put it inside of this hole, and they keep it. We call it compression plate. So 95 degree condylar compression. It's going to be inside and keep it by the hole of the device. So the chance of movement is nothing. There is no chance for movement. The stability is very good. So when you see that the patient does have a kind of very simple plate or DCP, so the stability is lower compared to that one. If you use a plate just here, but here the 95 degree is so strong, so the stability is so strong. What does make you different? What is the make a different idea for you? Clear, you see that okay, the surgeon use it 95 degree. So as a result, the stability is very good. No need to delay for 10 days and start some movement. You can easily, gently use some kind of movement. For instance, 2 days, 3 days, 4 days after surgery. 2 days surgery, 4 days after surgery. You can stop. Why to have weight? Okay? Clear? And this is the picture, lovely picture of 95 degree condylar plate. As you can see, there is a huge gap here. It's hard to fill this gap with the bony tissue. And the gap is here, but there is 95. And this is a DCP plate or is common plate? Which one? DCP or common? What was DCP?
Dynamic compression plate.
Good. You were? Sajjad. What? Fatima. Good, Fatima. Thanks. Okay. Is that DCP? DCP is much stable compared to common actually plate.
Common plates.
Is that DCP? Yes, it is. See, the size of the hole is more than just a screw.
Yes.
See, it's more than just simple screw. It's DCP. Just push it inside and just slide. So, would be much stronger, much stable compared to normal size. Okay, and see just such a kind of 95 condylar compression plate can fix these two fragments close together. And there is a rule, there is the general rule for the orthopedic situation, orthopedic problem. And whenever you have a kind of fracture, you must see that the chance of the healing would be good if the distance between two fragments would be 1 centimeter or less than that. If the distance would be more than 1 centimeter, so the chance of healing would be decreased. So the chance of delay union, non-union would be increased. It's huge distance, it's more than 1, probably 2 or 1.5. Anyhow, in case you have close contact, close distance between two parts, so the chance of healing would be good. And so sometimes you have a complicated fractures, you lose part of the tissue, and probably the distance between the fractures or the area between the fractures is too high. So there is no other option for the people, for the surgeon. He or she may use just the kind of good fixation, such a kind of 95 condylar compression plate. And so sometimes they leave it in this way for a while, at least for 1.5 years, and let the biology do something or fill the gap. And sometimes it's not possible. They are using some specific material to inject in this area to increase the chance of some specific materials. Because of the immunologic reaction, they are using the crest of iliac, creating some kind of a specific, for the patient, crest of iliac, removing it, bring it on the laboratory, make it actually a little work on there, increase some specific type of protein. We call it BMP, bone morphogenic protein. Use bone morphogenic protein, inject to this area to stimulate the distance to be much solid healing process as soon as possible. As soon as possible. Inject the BMP inside of this tissue. Sometimes the distance is too much. For instance, there is a gap between two parts of the bone from here to here, for instance. And car accident, motorbike accident. So you can use part of the bone extra which you have in your body to put a kind of link between two fragments of the bone. So we call it bone graft. Use extra part to put it inside of this gap, huge gap. We call it bone graft. So where can we find extra bone in our body? For instance, you have a gap in, for instance, tibia. Can I remove, for instance, half of the humerus, put it on the tibia? What is happening for the humerus?
So we short.
So you make it paralyzed. Right. So it's not possible to remove the middle of the humerus, or probably a skull. Where it's just one place, just one bone. Just easy, cozy.
Another thing.
Where is it? Femur? Can we cut half of the femur, bring it down? So how can they walk? Nothing. It's not possible.
From the ulna arthritis.
Allah?
Arthritis.
Teeth? No. Don't say that. You remove all of the good memories of your answer.
ما تخليها؟ حاجة بلاها فيك. راح تجيب عظمه تخليها هنا يعني
I'm talking
اكو بعضهم هذا يسوي هاي كلها شلون تنهشم خلص على الاستخدام تجيب تجيب
See what is extra bone? It's a kind of the excessive bone that God used the limit here for you. If you are committed, you can use it. So we can remove people because mostly 90-95% of weight bearing are happening through the tibia. So it's extra. If we have a huge gap, we can remove it, put it on the midsole in the gap. Did you get the answer? You were talking with each other. The excessive bone is fibula. 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 Shoot. No question. No question is good question. Okay. Okay. We do have different type of the screw, and you can see there are different type of the screw used for cancellous bone, for the cortical bone. The length of the screw are different, 4.5, 6.5, 2.5, 4 something. Very important point about this screw. Very important point about this screw. The important point is, actually when we are using the screw, the width of the screw is important. The width of the screw is important. The width of the screw, the width of the screw, okay? When we are using the screw inside of the body of the bone, the most amount of the width that you can use it for the screw is 20% of width of the bone. If you are using more than 20%, you are increasing the chance of refracture for the bone. So, for instance, if you have 10 millimeter for the bone, width of the bone, 10 millimeter, the highest amount of width for the screw would be 2 millimeter, 20%. Okay, 10, 2. So if you are using a screw with 3 millimeter width, so you are increasing the chance of the refracture. So don't have a look to the x-ray and see that, okay, do you see that there is a very lengthy actually width for the screw, and say that, okay, surgeon is not, sorry, kind of extra width, and so width of the screw is much higher compared to the normal spot. Don't tell just imagine what am I saying. Don't tell to the patient, okay, the width of your screw is too high. Don't let the information transfer to the patient, or don't send any kind of simulation for kind of fight with the patient or physician. So you see that the risk of fracture is a little higher, okay. First, talk with doctor and say that, doctor, is there any specific, the physician, is there any specific reason you created, you use this kind of width for the screw? He may actually forget to check it early entry, and he found that, he will find that, okay, you understand what are you doing and try to solve the problem. No, it's okay, nothing more. But because you have the knowledge of this idea, so you are not providing any kind of excessive force, because you know the risk of refracture is so high. You are not providing the force. Delay the force, okay? So, good. We talk about that. There is another type of the screw, we call it sliding compression or the sliding hip screw. It's exactly like a compression plate. There is a kind of spot, and you have the screw which is going inside and fix with the whole canal and provide a good stimulation. Everything was good here, just the only point is, because of the shape, it's usable for neck of the femur, so you can see neck of the femur. And the neck of the femur is the weakest part of the bones, weakest part area of the bone healing. Why? I told you, I explained for you before. No. Why the neck of the femur is the weakest part of the body in a skeletal? We have three parts which is very weak. First is neck of the femur. The second one,
surgical neck in the humerus.
surgical neck in what? Humerus?
Humerus, yes.
Surgical neck again for femur. The same, actually, the same area. This is the first one.
Oh.
The second one is scaphoid, proximal part of a scaphoid, little over the area of the wrist. You know the scaphoid. How many bones does we have in the wrist?
8.
8. From proximal to distal, from outer to inner area, scaphoid, lunate, trichotium, pisiform, trapezium, trapezoid, cartilage, hamate. Okay, scaphoid is a weak point because here in the neck of the femur or in a scaphoid, we don't have good circulation. Here we do have good circulation, but there is a kind of limited circulation. There's just one artery around the neck of the femur, circumferential femoral artery, and if you have a kind of fracture on the neck of the femur, because of limitation of circulation, if you at the same time, most of cases you do have a kind of injury on the artery as well. And if you lose the artery, no chance for healing. No oxygen, no nutrition, no food. Done. So it will be necrosis. You know the meaning of necrosis? Dead. You know the meaning of death?
Yes.
It will be necrosis. So what does that mean? It will be approximately dark color, necrosis, shrinkage, just lose the water, and it does not work as a kind of vital sign. It would be source of pain, because always he feels pain when he's living or something. And also source of the pain and function will be disabled. It cannot possibly use this part of the body. So you are not always able to use this kind of sliding screw because sometimes there is no circulation. In case of no circulation, we're removing head of the femur and use another prosthesis, probably one of the old guys in your family, after you get a kind of fracture, when he's falling from a short stool, just a very small short peg, for instance, wants to clean the window or something like that. If she or he get a kind of break in the neck of the femur, it will be in the necrosis, and so it will be under the surgery of prosthesis. This prosthesis, we call it prosthesis more. This is the name of the prosthesis. They use the prosthesis more. A specific time from the quality of 316L, because the risk of corrosion is low. So using the prosthesis inside of the joint. Okay, did you get the concept? Just a little move further, then I'm asking you to review these items in your small group. Sliding keep a screw, you can see the screw here in the X-ray, as you can see. And here is Krishna wire, is exactly like a kind of little intermedullary nail. It's Krishna wire. We are using the Krishna wire for the middle part of the very small bone, a small long bone, such as kind of metacarp or phalanx or something like that. They're exactly like a kind of long bone, but very small size, phalanx or metacarp. So we are using the wire. One of the most famous one is Krishna wire. It's based on the name of the founder, Krishna wire, and it provides a kind of stability on the whole of the fingers. Why we call it? What is the most dangerous risk, most bad risk in wire? What is that? It's located inside of the medullary canal. So somehow it disrupts some part of the canal. So we need central canal. Why? Because it's source of the osteoblast. So the surgeon must be very careful when he's using that. In other way, when he's using the wire inside of the central canal, he is actually affecting joints, BIP, PIP, and PIP. Okay, so, and you know the type of this joint? The type of this joint is PIP, and PIP is hinge, pure hinge, pure hinge. And where did you find another pure hinge? Just elbow. We do have pure hinge just in elbow and actually PIP or DRP. Hinge joint is very, very limited weak joint. Why? Because this is just 1 degree of freedom. You pass actually biomechanic to 1 degree of freedom and also just flexion extension. This is the quality of hinge joint. If you have a kind of obstacle in the hinge joint, what is happening? What is happening? Hinge. This is huge hinge joint. Just a small, this is plastic, that was the reason they changed this shape. A small amount of the obstacle in hinge joint, you cannot move it. Lock. But for condyloid joint, such as saddle joint here, condyloid joint, you know, the tongue is going in front of the others. This is the difference between monkey and human. Monkey, ape hand, all of the fingers are parallel. But human can bring it in front of their other 5 fingers, okay? In some deformity, when we lose this area of the muscle, we call it monkey hand or ape hand. Ape is big monkey, okay? Gorilla, ape hand. But if you have enough movement in tenar position, so you can have opposition to bring it in front of the others. So, in a saddle movement, in a condyloid joint or saddle joint, so because there is 2 degrees of freedom, there is a chance to provide a kind of mobilization and then use another part of the range. But in pure hinge, there is no chance for any kind of mobilization. You are fixed. Okay? So, knee is a kind of hinge joint. Knee is a kind of hinge joint. What is the type of knee? Type of condyle, yes. It's not hinge. You may say that, okay, it's flexion extension, but in knee, we do have external rotation as well, and internal rotation as well. And because of this creature, this situation, so if there is a loose body, there is a stockel on the knee, we have the chance to provide a kind of mobilization and then use the complete range. But in elbow, it's not possible, right? So when we are using this nail, we are destructing the joint. We are destructing the joint. So that was the reason we have to remove this nail as soon as possible. Because they are a small joint, a small bone, it's okay. You can actually remove it as soon as possible. And how long after fracture, after using this nail, how long it would be? Initial session, the first, second session. Even I told you today, how long after fracture, after usage of a wire, you can remove this wire? Logical reasoning.
3 weeks?
3 weeks. 3 weeks. She is eligible for a month. 3 weeks. Why 3 weeks? So I can mark, get back the mark. Why 3 weeks?
It's the first one.
The distance of modeling and remodeling. Okay, good. 3 more. Yes, 3 more. 3 weeks. Mostly between 18 to 21 days, we are removing that. But for a plate inside of the femur, tibia, in general space, we have to keep the ORI for about 1 up to 1.5 year, to be confident about the stability or something like that. There is a biomechanical reason behind that. I will explain it later for you. So sometimes, when the surgeon do this actually surgery, just provide a curve at the end of the wire and put it out of the finger, out of the pad. There is a kind of bandage, a splint, and the nail, actually, the end of the wire is out of the pad. And so, why it's out of the pad of the finger? Because when he's coming to you, you see that, okay, there is a nail inside, and don't do a kind of movement. If everything gonna be inside, he doesn't feel anything, and probably in treatment when he's reversing the bandage or coming to the therapy, so you may provide some kind of flexion and extension. And what is happening? When the wire inside of the fingers, and you're providing some flexion extension, demolish everything. So they destroy all of the story. So this tip of the fingers shows that there is a nail inside the bone, and don't force on the bone. And sometimes it must be completely, the patient must be completely alert. Think about the knees, nails. Sometimes it provide a kind of bad connection to the part of the clothes, or part of the door or somewhere else, or even when he opened the door for the car or something, might be provide a connection to the door or clothes or something, and bring it out very simply. So he must return to the hospital and get another again intermediary under the actually general anesthesia again operation. So it will be fatal again. And sometimes the patients come out to the home after the surgery and see that, okay, there is a part of the nail out of the finger, and say that, okay, my surgeon forget to make it wrap up or bring it out or remove it. So use a kind of nail cutter to make it easier, make it nicer. And so when she or he, the patient, come to your office, you don't see the nail and provide some flexion extension, destruct everything. So that means actually you must be curious about the situation. Don't touch any kind of fracture. Don't touch any kind of fracture without watching X-ray. First see the X-ray, then start to work on that. Without watching the X-ray, no, nothing. Okay? So you must be confident about the situation of ORI or the fixator.